series of interviews with the giants of cardiac surgery. My name's Joel Dunning and I'm here with Marc Gillinov from the Cleveland Clinic. Marc, you hold the Judith Dion-Pyle Chair in Heart Valve Research at the Cleveland Clinic, and you're also Surgical Director of the Centre for Atrial Fibrillation there. You performed over 4,000 operations, you've got over 200 papers, and I've counted that you're at least on the editorial board of 4 journals. You also hold several patents for novel techniques in mitral repair, and you have a special interest in robotic mitral repair. And it's the minimally invasive and robotic techniques of mitral repair that we want to talk to you about today. We want to talk about your exact techniques and hints and tips for people who might be doing this technique or thinking about changing to it. So we'll go through your technique, but first of all, perhaps you could say a few words on why we should go minimally invasive. One of the best surgeons in the UK is Frank Wells. How would I persuade him to buy a robot or go minimally invasive?
I don't know if you could persuade him, but the reason to do an operation less invasively is to get a better overall outcome. So if you can achieve the same mitral valve repair with the same safety profile, with a smaller incision, less tissue trauma, and a quicker recovery, then you've done something good for the patient. So that's the reason to do it. Basically, just to do a better job.
And again, which patients are suitable and which maybe aren't suitable? I know obviously a patient you can't get into the right chest or don't have femorals, but do you have any patients that you particularly think, no, this isn't right for them?
Absolutely. There are some surgeons who say, I always do it this way because it's the best way, whichever way that is. There's no always best approach. The best approach in a given patient is the approach that gets the best result in that particular patient. So when would I go through the right chest? Today, most patients think of minimally invasive as going through the right chest, with or without the robot. I would go through the right chest when the valve and the patient are right for it. The valve means it's a valve that I can repair or replace fairly easily. If the valve has severe angular calcium, I would still favor some sort of sternal approach because I think it's safer. Then there are perfusion questions that need to be answered before you go through the right chest. Mostly is perfusion going to be safe? We tend to perfuse from the femoral artery and vein when we go through the right chest. If the femoral artery is too small, meaning less than about 6 millimeters, that is not a good idea. You're going to damage it when you cannulate it. In addition, if somebody has aortoiliac atherosclerosis, you don't want to perfuse through the femorals because you increase the risk of an embolic stroke. Finally, protection. Go through the right chest only if you can protect the heart as well as you would going through the front. The one factor that minimizes your chance of good protection is aortic regurgitation. If you go through the right chest and somebody has more than minimal aortic regurgitation, you're going to face protection problems. If your retrograde catheter comes out and you're relying on antegrade, you may wind up with no protection. So I would not go through the right chest in somebody with more than minimal aortic regurgitation.
Okay. So you've mentioned cannulation. Let's get into theatre and get operating. Before we talk about the chest, how exactly do you do your cannulation femorally? Do you go percutaneous or do you open it up?
We open it up. So after the person is asleep and positioned, we do our echocardiogram, confirm the diagnosis. Then, before doing anything on the chest, we make a small incision over the femoral artery and vein to assess their size. We've already had a CT scan and an ultrasound looking at the femorals, but direct visualization is for us key. You could very easily get into a situation if you're trying to go percutaneous where the femoral is too small and you just shred it with your cannula. So we like to do it under direct vision, and it also lets us do the best repair possible at the end because you don't want to finish the mitral valve operation and narrow the femoral artery or vein and set the person up for peripheral vascular problems.
I know quite a lot of people now don't do an SVC cannula through right internal jugular. Do you always do that, or just?
We do it selectively, so probably 10% of the time we need an SVC cannula. We ask the anesthesiologist to place 2 catheters in the internal jugular vein, one for their use, one for our potential use. The reason is that if it turns out that you just can't get good drainage with your femoral venous cannula, you don't want to struggle through the operation. You want good drainage so you can see the heart. So we just stop for a moment and with saldature technique over the guide wire, change this extravenous cannula or extravenous catheter to a cannula.
Okay, and moving again onto your bypass technique, would you mostly use an endo balloon or chipwood clamp, or do you vary it?
These days we're mostly using chipwood clamp. It provides secure aortic occlusion, and then if we place an antegrade needle in the ascending aorta, knock on wood, we don't have trouble managing that hole at the end. So we get very secure cardioplegia and myocardial protection. The endo balloon, we go back and forth. You know, I'll have a nice run where it's working very well, and then I'll have migration or rupture or inadequate occlusion. And when that happens, I'll back off and say, oh, if I had just used a clamp, I wouldn't be facing these issues.
And you always go normothermic, or do you cool down a little bit? And what cardioplegia?
We drift. We drift in temperature, and we use standard blood cardioplegia, given every 15 minutes or so.
Yeah. And I think you just mentioned that do you always use retrograde as well?
Usually use retrograde. It's contingent upon my ability to get the retrograde catheter in. So if we're doing a right thoracic approach without the robot, what I'll do is place the retrograde myself. And if you take a long, straight retrograde and aim it like a spear into the right atrium and toward the left hip, so you aim it toward the left hip, about 80% of the time it goes into the coronary sinus, and you have echo guidance. If it doesn't, and there's no AI, we just use antegrade.
Okay, well, we better talk about chest incisions, because we're getting into there already. How do you make sure your incisions are the right height and you don't get too high and low, and what incisions do you make?
Almost always, the fourth inner space is the right incision. So after the person's asleep, we count the inner spaces, we mark the anterior axillary line, and then find your fourth inner space. The incision will begin for us laterally at the anterior axillary line, and then move medially for about 6 or 7 centimeters.
Yeah. And I've never actually seen someone physically setting up the robotic techniques. We've all seen lovely videos, and we've had a play in the conferences and things, but how does it technically work? Do you need 2 experienced surgeons, or do you scrub up, set it up and unscrub? How does it work with the robot?
Well, I would say, first of all, I think of the robot as an additional tool you can use when going through the right chest. So the right mini thoracotomy without the robot is very, very, very similar to the robotic approach with a right mini thoracotomy. The robotic approach, we make the incision a little smaller, so it might be 4 or 5 centimeters instead of 6 or 7. But really, to me, the robotic approach is a right thoracic approach to the valve, with the robot being one of your instruments. So if we're going to use the robot, we have gone through the positioning, we've exposed the femoral vessels, and then we make our access port, which again, 4 or 5 centimeters. You can get by with 4. And then you place the robotic ports. We have a special robotic fellow who is just outstanding. She gets them in the right place every time. They don't always go in the same place in every patient. So if our goal is to use the robot, or we've decided that's the right tool for this person, we make our access incision or port in the fourth inner space. The left arm goes in the third inner space anterior to the anterior axillary line. So about 3-4 centimeters anterior, heading medially. So that's the left arm, third inner space. The right arm goes in the fifth inner space, usually around the anterior axillary line. The camera goes in the incision, and the atrial lift retractor, which is the additional arm, we put that in the fourth inner space, a little bit medial to the incision, 2 finger breast medial. That's the usual guidance, but then you may have to vary it a little bit. And it's best to get your ports right in the beginning. So if you begin with the robot and you're doing the operation and you're saying, well, I've got conflicts and it seems like I can't get these instruments to work right, don't try to tough it out. Look at your ports and say, hey, I wonder if I move the right arm down to the 6th inner space. You can do it through the same skin incision. Maybe that'll help.
Yeah. Okay. And sometimes the diaphragm can ride awfully high and get right in the way. Do you push that out of the way sometimes? Or?
Well, when we do the robotic cases with a little mini thoracotomy, you can put a stitch in the diaphragm and then exteriorize that stitch low between the ribs and pull the diaphragm down. So last Monday, I made my 4th inner space incision, and saw nothing but diaphragm. And your initial response might be, then I need to move up an interspace or two. But looking at this man's chest x-ray, he basically had a very high right diaphragm going in. So we put a couple of stitches in the diaphragm, pulled it down, and lo and behold, once that mountain of diaphragm was cleared, there's the pericardium.
Great. And so getting into the left atrium, it's key for getting good vision of the valve, isn't it? Do you have any tips of a good left atrial incision, especially small left atria and things like that?
We make the same incision we would make through a sternotomy. So while the access is different, you're on the side versus the front, we make a standard left atriotomy. If we're doing it without the robot, we make it large enough to hold the retractor, and there are several different companies that make very nice retractor so that you place in the left atrium. They're about this wide. If we're doing it with the robot, we start with a smaller incision in the left atrium, put the retractor in, the atrial lift retractor, lift up, and then extend only as much as you need.
Yeah, and so we're looking at the valve, and it's time to make a repair. I think you described that really 98% of the cases you only need 5 approaches, so which is a nice simplified way of doing things. So maybe if we address firstly the most common posterior leaflet prolapse, what would you do to repair the most standard P2 prolapses?
Well, there's certainly now a different fashion catching people's attention. The idea of respect the valve versus resect the valve. I think the real idea is get a valve that works. Whatever's best in your hands, make the valve work. So my favorite thing to do for an isolated P2 prolapse is a triangular resection. It's a relatively old technique. They've been doing it at the Mayo Clinic, at the Brigham. It's probably as old as I am. But, you know, it works, and it's really easy. Just cut out a triangle and then sew it back together. After you do that, look to either side of your suture line. Make sure you haven't opened up a cleft. If you have, put a stitch there and close it. And then place your annuloplasty. So for most posterior leaflet prolapse, I do a triangular resection.
Use interrupted stitches to close it, or just a running stitch to
If
close it?
I'm with the robot, interrupted prolines. If I'm doing it by hand with long shafted instruments, a running suture.
Yeah. And a lot of people find the P2 prolapse is okay, but it's the anterior leaflet that worries them. And how do you approach the anterior leaflet, and when you're putting cords in things, how do you do that?
These days, for the anterior leaflet, I'll usually use artificial cords, Gore-Tex most commonly, CV4 or CV5. And how to do that? First, look at the valve, correlate what you saw in the echo with what you see on the valve, figure out which area is prolapsing. Then take one needle of the Gore-Tex, 2 passes through the papillary muscle, a figure of 8. Now you've got 2 needles. The strand is attached to the papillary muscle. Bring needle number 1 up through the leaflet, from the bottom to the top and bottom to the top. So again, a figure of 8 in the free edge of the leaflet. Needle number 2, do the same thing, up through the leaflet, and then back up through the leaflet. And the needles, or strands of Gore-Tex, finish near each other. Then comes the part that is always the challenge. How do you get the right length? I get the right length by estimating and looking at a cord next to where I'm working. So look at a normal cord, figure out if I lift the leaflet up, how far can I go in this normal area, and then just adjust your cord to that length. The most common difficulty is to make them too short. So I hate to say err on this side or that side. You don't want to be making errors, but lean toward making your cords a little longer than you think they might need to be.
Just use a measuring tool, or this is eyeballing?
This is eyeballing. There is a nice measuring tool available that you can use as well. But these days we just tend to eyeball it. And it turns out that you've got some leeway. The cords, let's say 22 millimeters would be the exact measurement. If you get 21 or 23 or 19 and a half or 24, in most cases that's going to be fine. So this is not an exact measurement that needs to be absolutely precise or it won't work. You've got a range.
And do you use sort of commissural closure quite a lot, or is that or you don't do Alfieri stitches that often?
At the commissure, yeah, we do use it. So on the echo, if somebody's got bileaflet prolapse at a commissure, the cardiologist will frequently say, this is a very complicated valve. The problem is at the commissure, we've got both anterior and posterior leaflet prolapse. When you hear that, you just smile. Because, yeah, it looks like a complicated echo, simple repair. Just close the commissure. The only thing to watch out for there is mitral stenosis. If you close the commissure, obviously you've decreased the valve orifice. Don't undersize your ring. Put a good sized ring. And as long as you close the right amount, don't go too much closure, and put a good sized ring, you'll have a nice valve that'll work fine, will not be stenotic.
And with regard to annuloplasty rings, what do you prefer to use? And also I think you sometimes use a continuous stitch, don't you, for your rings?
For degenerative mitral valve disease, we favor a flexible band. Why? Two reasons. First, because I don't believe that for degenerative disease, the type of prosthetic annuloplasty matters. I think what matters is that you use one, whichever one you like. Secondly, the bands, these flexible bands, are easier to place through the right chest. And then you said, what about using a running technique? With the robot, that's easier still. One of the biggest early criticisms of using the robot was it takes a long time. Well, it does take longer if you try to do exactly the same thing with the robot as you would through another approach, but you should make your approach fit the patient and the robot. And it turns out that if you do a running annuloplasty, and this also is old, it's another example of old coming back to new. Do a running annuloplasty, it works just fine, and it's quicker with the robot.
Would you do running open as well now these days?
I don't, not because I don't believe in it, but because when I'm doing it open, I like to put the annuloplasty stitches in and pull them toward me individually, and it pulls the valve toward me. So the annuloplasty done open, or through the right chest without the robot, those stitches help me with exposure.
Okay. So we've done our repair, and I suppose absolutely key is checking the repair. What steps do you do to ensure good coaptation distance and that it's an absolutely perfect long-term repair?
Oh, absolutely perfect is a high bar, but that's what we shoot for. I will have obviously looked at the echo and then looked at the valve, then done, in most cases, a standard repair for a standard problem. And usually a standard repair works perfectly well for a standard problem. Then I do test the valve, so I'll run antegrade cardioplegia and let the ventricle fill and look for any leaks. Every once in a while you see a cleft or perhaps there's something you didn't notice. Fix that. Then de-air, close the left atrium, and see what happens when the heart is beating. And when you look at that echo with the heart beating, you do not want to leave more than mild regurgitation. So if you look and you say, wow, there's almost none, you can always find a little bit, but if you look and say there's almost none, that's good. If you say it's definitely no more than 1+, that's still all right. If you're looking and the echocardiographer says, yeah, it's probably not 2, but more than 1, that's not good enough.
And do you measure coaptation distances a lot, or is it mainly on the regurgitation level?
We base it on valve function, meaning the regurgitation level. It makes me feel good to see nice coaptation, and there are people who say the more coaptation you've got, the longer the valve will last. We don't have any concrete data to say that's true, but we do know this. If the valve works when you leave the operating room, that's a good thing. And if the valve doesn't work, meaning it leaks, it's not going to work.
Yeah. So just moving on, tricuspid repair gets more and more common, and what are your criteria for addressing the tricuspid valve? And I know at Cleveland Clinic you don't just always put an annuloplasty ring in.
I would repair the tricuspid valve if any echo, whether pre-op or intra-op, showed that the leak was moderately severe or severe. In addition, if the person has pulmonary hypertension with moderate tricuspid regurgitation, I would lean toward repairing the tricuspid valve. I do not currently do something to the tricuspid valve when there is angular dilatation and the valve doesn't leak. It's hard for me to become excited about repairing a valve that's not broken, meaning it functions well. I know there is some data suggesting if the annulus is dilated, it's going to leak in the future, but we don't yet have the data, the real strong data, saying that we're doing someone some good by doing something to a valve that functionally is fine.
And and I'm sure a huge number of your patients have got atrial fibrillation. They've obviously got large left atria. What percentage of the time are you doing maze procedures, and what actually would you do for somebody, say, with paroxysmal AF and a sort of 4 centimetre left atrium?
Well, actually, what we're doing most importantly with the mitral patient with atrial fibrillation is an NIH-sponsored study to try to determine what we should do. If you talk to surgeons around the country, they'll say, person's got mitral valve disease and atrial fibrillation. They do one of three things. Some of them do nothing for the rhythm. They say the valve is what drove the atrial fibrillation and they fix the valve. Some people do a full biatrial maze lesion set, and some people just do pulmonary vein isolation. Which one of those three is better for the patient? We actually don't know for sure. My instinct in the past has been to do a biatrial maze procedure in most people with pre-existing atrial fibrillation. I'm not currently positive that that's the best thing, and with this multi-center trial, we hope we'll be able to tell people these are the cases where you should do just the valve. These are the cases that warrant pulmonary vein isolation, and a biatrial full maze lesion set, as described by Dr. Cox, these are the right patients for that.
Okay, very interesting. And yesterday you did a very interesting interactive session about the atrial appendage. Do you take it off the whole time like you were taught, or who gets their appendage removed?
Well, there I think we're on a little more solid ground, at least in what we believe to be true. Anyone who's had atrial fibrillation, we will either oversew or resect or clip off the appendage. And we think that is a good thing for patients. Most blood clots will form there, so if we exclude it or cut it off, we have probably done something good. So any atrial fibrillation patient gets something done to the appendage. Then as far as what are we going to do ablation-wise, that's what we're trying to figure out.
And physically, in terms of closing the appendage, what do you actually do? Because you can get it very wrong, can't you?
Yeah, the appendage is an opportunity to create some real havoc. If there is clot in the appendage, I will tend to cut it off once the heart is arrested and retrieve that clot and remove the appendage completely. If there is no clot in the appendage, I like to use one of the new devices, a clip or something of that sort, because it's atraumatic. If you decide your favorite way to do it is to oversew it from inside, you have to be careful of two different things. One, that you make a permanent closure, and two, that you don't create a problem like bleeding or a circumflex injury. So if I were going to oversew it, which I don't do very often, I would take 2 layers of running suture down and up.
And can you get the clip in from the right thoracotomy, or do you have to make a separate incision?
I can't get it in from the right thoracotomy currently. So if I'm doing a right thoracotomy and want to do something to the appendage, I would actually oversew.
Yeah, okay, fine. And I suppose right thoracotomy is not the only way to do minimally invasive mitrals, and I think you have some experience of sort of upper hemistenotomy approaches. Do you do that much these days, or?
Not so often, but the partial sternotomy approaches are just fine for mitral valve surgery. They are still less invasive. The incision is smaller, blood usage is less. I do that when the right thoracic approaches are contraindicated. So femoral arteries are small, there's aortic regurgitation, there's aortoiliac atherosclerosis. Then I say to the patient, we still have a less invasive approach for you, just not the right chest because it's not as safe.
Great, well, that's a great insight to it. So we obviously closed the chest, and I believe you've got some new gadgets for clearing chest tubes
yeah,
in the Cleveland Clinic. I love those pictures. Can you tell me about those?
Yeah, one of the issues you have post-op, sometimes, I have to admit it happens to us too, is bleeding. And this is just part of cardiac surgery. We do everything we can to prevent bleeding, but sometimes it happens. And in cases where it happens, your chest tubes need to be working so you don't get tamponade or retained hemothorax. And we are all familiar with a whole bunch of different ways to try to get chest tubes clear. We strip them, we bang on them with Kelly clamps, we bend them, we increase the suction, decrease the suction. But those are all fairly primitive. And I thought, along with a group of friends, John Liddicoat at Boyle and a bunch of very creative engineers, it can't be that hard. I mean, to keep a drain open, to make the drain keep doing what it's supposed to do, to improve patient safety, there's got to be a way to do it. And actually, Billy Cohn as well we came up working together with a way to just floss it out, to have a catheter, a very fine catheter in the middle of the tube, and you, without breaking the seal, run the catheter in because it's magnetically coupled to a washer. So run the washer down the tube, and it sends your catheter in the middle of the tube, clears it out, then pull it back, and it cleans it out. And we've just started using this. It just got FDA approval a little while back. And it works very nicely. I mean, it's simple, it's intuitive, and it's just another thing to make it safer.
Sounds great. Well, it's been absolutely fascinating talking to you, Dr. Gillinov. Thank you very much for this interview.
Oh, thank you.
And it was an absolute pleasure. Thank you very
Thanks.
much.